Hello and welcome to a very special edition of the Lipid Insights podcast. I'm coming to you live from the FNLA Fall 2025 Clinical Lipid Update in beautiful Scottsdale, Arizona. I'm your host, Dr. Peter Jones, and I really couldn't be more excited about being here surrounded by some of the brightest and most passionate professionals in our field. If you're tuning in from across the country, the podcast is your backstage pass to learn about ideas and conversations and the energy that makes the Clinical Lipid Update experience unforgettable. So we've got a fantastic discussion ahead. So let's dive into the spirit of the FNLA Fall CLU. So today I've got two guests with me. My first one over here on my right is a good friend of mine for a long time, Dr. Bob Eckel. And he's the founder of the lipoprotein apheresis program at the CU Anschutz Center. He's also a certified endocrinologist. He's been the past president of the American Heart Association, the ADA, and the Obesity Society. I mean, he's all into metabolic health. So what do you do every day?
I'm a utility player, Peter.
Yeah.
I'm not sure what position I'm in, but I don't play very well at any of them, but I play a little bit of shortstop, a little bit of right field. Yeah.
Right field.
For injured players, if you're
But every
fine.
day, what drives your passion?
Well, my passion's been curiosity. I think, I can reflect just briefly. As a medical resident, went to medical school to be a doctor. And when I ultimately came about halfway through my internship and medical residency program, I started wondering more why people got sick rather than simply making a diagnosis and treating them. Of course, I want to be a good doctor. I want to make the right diagnosis and the right therapeutic approach. But my curiosity was driving me to think I need to do more in terms of understanding disease mechanisms. So at that point, I had to decide whether I wanted to go and do infectious diseases where I had some scientific background or whether I might choose endocrinology metabolism. So I chose the latter in part because I saw the relationship, potentially seeing the relationship between metabolic diseases like diabetes and obesity and metabolic syndrome and how that related to cardiovascular disease to follow.
That's fantastic. And my other guest who's also giving a lecture today is Dr. Samuel M. He is currently the director of preventive cardiology and an assistant professor of medicine at Weill Cornell Medical Center in New York City. Welcome, Sam. What drives you in your daily practice?
I want to echo Dr. Eckel's point. I see myself as a utility player too, all over the field. I think certainly, I think trying to catch disease upstream and prevent it has sort of been my passion. And I think the more and more through training, even though the technology is evolving to treat more complicated disease, I think we got to do the basics better and do it really well. And so I think that has kind of generated this interest in preventative cardiology. It started more with lipid focus and I've had to evolve kind of like the NLA in terms of treating cardiometabolic disease as well too, and learning how to utilize some of these newer therapies as well too. So it's been exciting.
Okay, that's awesome. Well, Bob, your lecture is really about obesity and metabolic health, and so it's a great lecture. One of the things I want to do is tee this up for you a little bit. Is there a class of people that you can call metabolically healthy obese?
Well, the term has been out there for a bit of time now, and I'm going to reflect a little bit of data as how that's defined. But ultimately, and I can share with you, I've been a major part of what's called the Lancet Commission on Obesity. And there we're kind of redefining the playing field and trying to define beyond BMI who has excess body fat. BMI is a good kind of SED rate, if you will, for excess adiposity. But it doesn't look directly at body fat distribution. It doesn't look at total body fat content. And obesity is defined historically by excess adipose tissue.
Right.
Now, back to metabolically healthy obesity, we kind of dismiss that term, not because it's not accurate. When I think of metabolically healthy obesity, I think about cardiometabolic healthy obesity.
Right.
But what we've defined is assessing body fat content as the normal or excessive, using the BMI as, again, the SED rate to approach that diagnostic approach. And then deciding whether people had illnesses that we could relate to excess body fat. And by the way, we have a list of 18 organ systems which we define as clinical obesity, meaning people with obesity, excess body fat who have illnesses. But then back to metabolically healthy obesity, we define another term of preclinical obesity.
Oh, okay.
And preclinical obesity is excess body fat and perhaps at risk for disease to progress, but at this time they're healthy. There's no quality of life issues. They have no end organ disease of any kind. They have no lifestyle modifications in terms of daily living. These people have preclinical obesity. So that would be, if you will, a metaphor for metabolically healthy obesity. So that term we've coined and published, and now we're getting a lot of input from other cohorts in terms of whether that's accurate or not. But that's what we defined, and that's really what I'd like to call metabolically healthy preclinical obesity, excess body fat, no illness.
Is that an age-related thing? I mean, are you more likely to see adolescents and with preclinical obesity, and then later on, it becomes bad clinical obesity, or can somebody in their midlife or late life suddenly get obese but still be metabolically healthy?
Well, I'm playing a minor role in examining 4 cohorts internationally. One is the All of Us study here in the U.S. One is the Spanish population, where in fact we don't have advanced measures of body fatness. Then a huge population from China, where there's longitudinal data, and ultimately the UK Biobank. So those 4 cohorts, we now have longitudinal data looking at the definitions we've defined and looking over intervals to see how many people maintain preclinical obesity versus transition into clinical obesity. That's a work in progress right now, actually. And I don't want to report that data because it's not been peer reviewed yet or published. But nevertheless, it's an important question.
Yeah. Do you have any thoughts on that, Sam?
No, it's a good question because I think the definition drives how we treat disease. And I think all of us just kind of go by BMI at this point in clinical practice, and we know that that's not the most accurate representation. So I think I know there have been some registry study looking at waist circumference and ratios, and the uptake of that has been very low in clinic. And I can say even within our cardiology, I can't think of the last time that anyone is routinely checking waist circumference. So
well, yeah, I mean they call it the fifth, the fifth, the vital sign that's right there in the clinic. I mean, you could if you wanted to, when you measure the vital signs, it's the 5th one. Why aren't you doing it?
Well, we got all these guidelines to measure blood pressure correctly. Don't cross your legs.
Yeah.
And you need to be seated carefully and silently for 5 minutes. And all these kinds of things. Having a medical assistant do a waist circumference doesn't take a lot of time. The doc, he or she doesn't need to take the time to do that. And you get a height and a weight, you can do a waist height ratio. I mean, everybody doesn't need a DEXA. In fact, very few people need a DEXA, but that would be more of a quote gold standard measurement.
Well, yeah, the DEXA is the best for looking at where your fat distribution is, as well as percent body fat and all. But that's important. Sam, your presentation is going to be on GL1 receptor, GL1P receptor agonist. When was the first one came out? 20 years ago? Exenatide or whatever?
About 2005.
2005, so about 20 years ago. And in the last 5 years, they aren't just for the treatment of diabetes; they're now exploded into the treatment of obesity. And so it's just amazing where they've come. So they do help people lose weight, semaglutide, liraglutide, and tirzepatide. But there's more to their benefit than just weight loss. What do we know about GLP-1s and their effect on cardiometabolic health?
Yeah, I think it's a complicated question because the field is rapidly evolving. I will say, even when putting together the slides for the talk, I've had to change it every week because there's a new discussion, a new topic, a new trial. I think certainly we do know that it's indicated for type 2 diabetes and obesity. In the last couple of years now, we have seen cardiovascular indication both for atherosclerotic disease and particularly for heart failure endpoints. And particularly, we are seeing more symptomatic improvement in the heart failure cohort. The hard endpoints are still to be determined. So there are relatively low event rates on that. But in the last year now, we have new indications for CKD and type 2 diabetes and progression and, for CKD outcome. And secondly, we also have outcomes data for people with fatty liver disease, or now what we call metabolic associated steatotic liver disease. So it has really changed the field of how we treat cardiometabolic disorders, and also sleep apnea with tirzepatide in the SURMOUNT OSA that was presented. So it is now becoming not just the field of just obesity medicine or endocrinologists or cardiology. It's a field. I think it's impacting all of the subspecialties. Huh?
Sam and I was part of a recent editorial, which, just contributed somewhat to the editorial, but the evidence is fairly strong that weight loss is not the major explanation for a lot of the benefits, which relates to the science. However, these drugs working where there's no GLP-1 receptors in the heart, except maybe in the conduction system, and in the liver, there's no GLP-1 receptor action going on with GLP-1 receptor agonists. So, I think this is a fascinating door that's been opened to understanding the science better. And Dan Drucker, who's kind of the father of this whole field, doesn't understand. He publishes all the potential other effects. And is it inflammation? There's a little bit of an effect there. But anyway, this is an exciting time scientifically.
It is, isn't it? It's
Absolutely.
really, really amazing. And of course, now they're combining, besides GLP-1 receptor agonists, like tirzepatide, you've got GIP as part of that. And then you've got another drug that's also a glucagon receptor agonist, so triple therapy. Where do you see that benefit going beyond just GLP-1 receptor agonists? Do you see these combinations being unique, better, or selected for certain patients?
I think that's a great question. I think certainly, from a patient's perspective, the degree of weight loss will likely, be the first question is, are there going to be additional weight loss than the traditional 15 to 20% we're seeing with semaglutide and tirzepatide? I think there are still some concerns about the GLP-1s in terms of some of the side effects, whether, dropping the glucose too quickly may be resulting in some of these eye-related issues and stuff.
Right.
So the potential is, are these combination therapy going to maybe decrease some of those side effects? We're not sure. I think even GIP is really not well understood. We're looking at agonists and tirzepatide, but there's also a compound that's being studied as an inhibitor. And so that maybe this may actually potentiate the effect of GLP.
Sam, I'm really pleased to hear what you just said, because thinking about reducing glucose more rapidly or severely and causing retinopathy, you're speaking like an endocrinologist.
I know.
This is great. This is cardiometabolic medicine.
It is. It's all of it together. I think that's wonderful. But I do think the other area that is again not followed well enough by primary care doctors or even some lipidologists is what you call about MASLD, metabolic associated dysfunction associated steatotic liver disease. And how do you reverse that and prevent it from moving in fibrosis onto cirrhosis? And I think there is some early data to suggest that you don't just decrease the fat in the liver, you actually improve fibrosis scores with some of the GLP-1 receptors, right?
Yes, I think the Essence trial, which was looking at semaglutide, showed it actually was in the interim analysis at 72 weeks, showed improvement both in steatohepatitis and also with fibrosis, which was sort of a little bit surprising, but I think pleasantly. And I think we have not had any good treatment for MASLD up until this point. And, these are patients who had histological biopsies that were studied. So,
Right.
And we'll have to see what the final studies show up with the follow-up in about 240 weeks. Huh?
Well, this may show a little bit of ignorance, but I hope not. But, there are certain criteria for prescribing either resmetirom or a GLP-1 receptor agonist. It's like F2 or F3 fibrosis for these patients with MASH, if you will. But, the issue of, do you reverse fibrosis, or because the liver is so good at regenerating, in fact, are the fibrotic scores less because you have new liver cells that have replaced cells that may be necrotic or damaged? So I think, keep in mind, cirrhosis is not an indication at this time. So you have to be sure you're prescribing it for the right patient.
Yeah. I think you either get a biopsy or you use the FIB4 score to sort of give you an idea where you are on the patient's risk. But I still think, clinicians, even preventive cardiology physicians, aren't spending enough time thinking about massled and what they need to do about that.
Keep in mind that these drugs, not only the GLP-1 receptor agonists and biagonists and triagonists, were developed for diabetes initially and not for weight reduction, but of course we knew they would reduce weight. The SGLT2 inhibitors are also diabetes drugs, and now the platform and the mushrooming of effects in multiple organ systems,
Right.
we can't deny it any longer. But the cardiologists caught on a little slowly, but I think they're up to beat right now, Sam.
I think they are getting
They
there.
have to be.
Yeah.
Yeah, and there was a recent couple of articles in New England Journal of Medicine last month about semaglutide at the maximum dose for weight loss as an oral therapy instead of the injectable, and then also a new small molecule non-peptide GLP-1 receptor agonist, orforglipron, and their effect on weight loss. So where do you see the oral forms of these GLP-1 receptors going compared to what we know about the injectables?
I think it's a good question, because I think it's sort of, we have struggled the same thing in the lipid community in terms of how are patients going to respond to certain oral therapies versus an every 2-week injection versus an every 6-week injection. So I think some of it is still up in the air. But orforglipron, is a once daily small molecule. The advantage is that it's not based on your fasting status, certainly like something like oral semaglutide. So it may have the advantage for patient convenience. I mean,
They can take it when they're even eating, right?
Exactly.
Yeah.
And, we're looking at, somewhere in the low 1% reduction in A1C, which is fairly significant, and looking at about an 11% weight loss, which is certainly less than the injectable, but as an oral therapy, may be convenient for patients. So I do think, there's going to be a lot of interest in this, particularly.
Do you think they'll be less expensive as an oral option, like the semaglutide 25 compared to the injectables? If that gets approved first?
I would think so in the long run, yeah.
Well, the production line should be simpler, right?
Exactly.
For an oral therapy rather than an injectable. The other thing, the compliance, with the subcutaneous administration, I think I have an opinion that I'll share. I think after 6 to 12 months, up to a year, maybe up to 50% of people are no longer taking it. So how much of that's cost, or how much of it, I've lost a lot of weight, I'm not losing any more, and so I don't need to take the medication and pay a lot of money for it. I could stop it now. But we know data that looks at people like up to 3 years after stopping it, their weight comes back. So this is like blood pressure, like glycemia, like other things we treat chronically. Obesity needs to be treated chronically.
It is, it is a disease. I mean, that's what they would define it now. It's not just something that's that you drop it away and it goes away. It's a disease that persists. It does tend to come back. I mean, is it an option now that maybe you use the injectables because they do give greater upfront weight loss, but then do the patient have to stay on injectables for the next 20 years? Or can you switch them over and say, well, I've got an oral option for maintenance, and we'll take you off the injection. Now you've lost the weight, and now you just take this pill for the rest of your life. Would that be an option, do you think? Is that the way this might go?
I think that's certainly a possibility. I mean, one of the controversial topics has been on microdosing of GLPs as a maintenance therapy that a lot of patients and some providers are utilizing as off-label. And so it's not that hasn't been studied in clinical trials. That has, we don't know exactly what the effect of that. So I think if we can track as a maintenance, as an oral therapy, that could be potentially beneficial for our patients. Huh?
Yeah, I think the transition from injections to oral makes a lot of sense. And if cost is favorable there, I think that makes a lot of sense. We need good data to endorse that, but I think that's an important thing. Just your comment about obesity being a disease. We in the commission did not call it that. We're calling clinical obesity an illness related to excess body fat, but preclinical. We had 74 organizations worldwide sign on to the commission. And the AHA in particular was very strongly indicating we don't call it a disease. Now, the Obesity Society calls it a disease. The American Medical Association calls it a disease. I don't think we need to spend a lot of time there.
Right.
We just need to understand how to define it and the therapeutic decisions that need to be made related to it. So.
And just to emphasize that there's chronicity to it. I mean, it's not just a temporary thing. You get rid of the weight, and boom, we're done. Check the box, and we're out of here. I mean, we treat lipids, and you get a genetic lipid problem, or you have a tendency towards that, and you don't take a statin and it disappears. You've got to stay on it the rest of your life. You don't just take it and stop. Same with blood pressure. So, maybe obesity is one of those things that you got to look at as a chronic situation, a disease that needs a long-term strategy. I mean, I think it's been wonderful to watch how the NLA is beginning to accept this whole cardiometabolic health situation. We've got a lot of discussions as you guys are here talking about metabolic health and treatment of obesity. And Harold Bays will talk about the benefits of bariatric surgery in selected patients in your session. So, those are all part of the overall focus that lipidologists need to, grab onto and be a part of. And I think that we've also got a session on not just screening lipids in adolescents and pediatric population, but also about obesity in the pediatric population.
Very important.
And that is dramatically increased. I mean, and GLP-1s are approved, right? At what age for use in obesity? And
I think it's 10.
10 or
10 years
so,
old?
I think so, yeah. I have to double. I don't know off the top
Just
of
like
my head.
statin
Yeah.
therapy at 10, right?
at 10 years old? I mean,
Another thing I think that we're not going to solve here, I think we don't know exactly how to go about this, nor does anybody else, but we can treat obesity now with very effective pharmacotherapy or surgery. But prevention of obesity is a whole different public health problem, and that's a tough one. Because if you think about my analogy that I often give in a talk when I talk about cardiometabolic medicine as a whole, is tobacco use in the U.S. in the 1950s indicated that 50% of Americans smoked. In 2024, that's last year, it was 12%. Now that's 1 in 8 people still. That's too many.
yeah.
But it's taken 70 years to reduce it from 50% to 12%. Think about obesity and preventing obesity as a population. We got a real challenge there.
Absolutely.
And I don't think any of us know how to solve that one.
Well, we don't. I mean, there's a lot of talk about how we deal with ultra-processed foods and all that, and the government's trying to figure out how to help us with that as well. But I do think there is a tendency for too many people to stop at Chick-fil-A and McDonald's and Taco Bell and get all the wrong kind of foods, and we're sitting here trying to talk about how you maintain weight and do healthy lifestyles. Well, you can't do that when there's food like this all the way on every corner that patients have choices of. So it's a big
I think
problem.
that's one of the reasons I think that calling obesity a disease, we know it causes diseases and illnesses. There's no question about that. But, the patient, him or herself, have some responsibility. I mean, we can't deny that. And we know that underserved populations, cost of food, et cetera, we have all those issues are really relevant. And diversity here is a really important issue. But still, I mean, I think that some people can carry excess body fat and maintain that for a long time. And one thing that'll come up, I'll be interested in Sam's comments during our session this afternoon, is the issue of obesity paradox. And that's mostly for older adults where having excess body fat may not be harmful, like particularly in congestive heart failure.
Yeah.
Your thoughts, Sam, on that?
Yeah, I think that's a good point because even in the heart failure population, most of the patients we're going to see are going to be in the geriatric patients. And now, when you're losing weight and potentially muscle mass, what are the long-term consequences of that? And certainly we know that people with obesity generally have better outcomes even for stenting or cardiovascular procedures. It seems to be a protective mechanism to some extent. So I think we still need more data on kind of the long-term outcome for all of this before we make that. And I think it's important to have the conversation with patients that it's not just about losing the weight, but about improving your cardiometabolic stuff.
In my practice, I was very hesitant to take a very zealous approach to weight reduction. Somebody 75 and older,
Right.
I just didn't feel comfortable, and often the patients were not comfortable in trying to put on an aggressive program of weight reduction. So that's an opinion only.
Well, a lot of it also tends to be that they naturally tend to have, for any given weight, they do carry around more percent body fat than they do muscle mass. Yeah. For any given weight as you age because of sarcopenia tendencies and all that kind of stuff. You induce weight loss and you're fighting sarcopenia even worse, with GLP-1s, for instance. So at older individuals, that may not be a good thing.
Well, this is an active area of research now with antibodies or RNAs that modify the expression of myostatin or activin type 2 receptors. And this is an area where preservation of muscle mass may be possible in people that are GLP-1 receptor treated or even independent of that,
Independent of that.
frailty. Yes.
Yeah, that's awesome. Well, listen, guys, this has been a wonderful discussion. You guys have been fantastic. I know your presentations are going to be wonderful. And for everybody who's listening in, I hope you learned something, stimulated you a little bit. And maybe next time you'll be stimulated to come to a clinical lipid update for the NLA to listen to these kind of presentations in person. So again, thank you very much for being here, Dr. Kim, Dr. Eckel, and everybody for listening.